Welcome to this presentation on orthopedic injuries. Today, we will discuss different types of musculoskeletal injuries, their mechanisms, classifications, signs and symptoms, and emergency management. Understanding these injuries is crucial for providing effective pre-hospital care and improving patient outcomes. Orthopedic injuries typically result from significant force applied to the body. These forces can be classified into four main types: direct blows, indirect forces, twisting forces, and high-energy impacts. Recognizing the mechanism of injury helps us anticipate possible fractures, dislocations, and soft tissue damage. A fracture is a break in the continuity of a bone. It can be classified as either an open or closed fracture. Open fractures occur when the bone breaks through the skin, increasing the risk of infection. Closed fractures, on the other hand, do not penetrate the skin but still require proper immobilization and care. Fractures can also be described based on whether the bone remains in its normal position. A non-displaced fracture is a simple crack that does not cause misalignment, whereas a displaced fracture results in a deformity or distortion of the limb. Displaced fractures often require realignment and stabilization. There are several special terms used to describe different types of fractures. Greenstick fractures are incomplete breaks commonly seen in children. Oblique fractures occur at an angle across the bone. Pathologic fractures happen in bones weakened by disease, and incomplete fractures only partially break through the bone shaft. Additional types of fractures include comminuted fractures, where the bone is broken into multiple fragments, epiphyseal fractures, which occur in the growth plates of children, and greenstick fractures, which involve a partial break in the bone shaft. Proper diagnosis and treatment are essential to ensure proper healing and function. More types of fractures include incomplete fractures, which do not extend completely through the bone, oblique fractures, which occur at an angle, and pathologic fractures, which result from weakened or diseased bone. Recognizing these variations helps guide treatment and patient care decisions. Spiral fractures result from twisting forces and wrap around the bone. Transverse fractures occur straight across the bone. These types of fractures are often seen in sports injuries, falls, or physical trauma. Proper splinting and immobilization are key in preventing further damage. Signs of a fracture include visible deformity, tenderness, guarding of the injured area, and swelling. Some fractures may cause the limb to appear shortened or rotated. Suspecting a fracture early allows for immediate stabilization, reducing pain and preventing further complications. Additional signs of fractures include bruising, crepitus, a grinding sound when moving the injured area, false motion, unnatural movement where a joint does not exist, exposed bone fragments, severe pain, and a locked joint. These signs help confirm the presence of a fracture and guide emergency care decisions. A dislocation occurs when the bones in a joint are forced out of their normal positions. Sometimes, a dislocated joint may spontaneously reduce, meaning it moves back into place on its own. However, if a joint remains dislocated, it is considered a serious problem that requires medical intervention. The patient's history and symptoms can help confirm the diagnosis. Signs and symptoms of a dislocation include marked deformity, swelling, intense pain aggravated by movement, tenderness upon palpation, loss of joint mobility, and possible numbness or impaired circulation. Since dislocations can also damage surrounding nerves and blood vessels, prompt assessment and treatment are crucial. A sprain occurs when a joint is stretched or twisted beyond its normal range of motion, causing ligament damage. The most commonly affected joints include the knees, shoulders, and ankles. While sprains can range from mild to severe, they usually do not cause significant deformity, unlike fractures or dislocations. Common signs and symptoms of a sprain include guarding, swelling, bruising, ecchymosis, pain, and joint instability. While sprains can be painful, they generally heal with proper rest, ice, compression, and elevation, RICE, along with immobilization when necessary. A strain is an injury to a muscle or tendon, often caused by overstretching or excessive force. It leads to pain, swelling, and bruising of the affected soft tissues. Unlike fractures or dislocations, strains typically do not cause significant deformity, and swelling may be minimal. An amputation is the complete severing of an extremity from a body. This type of injury affects all aspects of the musculoskeletal system, including bones, muscles, tendons, nerves, and blood vessels. In a pre-hospital setting, proper management focuses on controlling bleeding, preserving the amputated part, and preventing shock. Orthopedic injuries can lead to complications, including systemic issues such as shock, infection, or long-term disability. The severity of complications depends on the force of the injury, its location, and the patient's overall health condition. Recognizing and addressing potential complications early can improve patient outcomes. To prevent contamination in an open fracture, EMTs should carefully brush away debris from the skin, but avoid probing the wound. One of the most devastating consequences of an orthopedic injury is long-term disability, which can significantly impact a patient's quality of life and ability to perform daily activities. Reducing the risk of long-term disability involves several key steps, including preventing further injury, reducing the risk of infection, minimizing pain using cold therapy and analgesics, and ensuring timely transport to an appropriate medical facility. Prompt, effective pre-hospital care is essential in mitigating complications. The golden hour is critical when managing orthopedic injuries, as prolonged hypoperfusion can lead to severe complications, including tissue death. Any suspected open fracture or vascular injury should be treated as a critical emergency. While most musculoskeletal injuries are not life-threatening, prompt assessment and stabilization are vital to prevent further harm. The golden hour is critical when managing orthopedic injuries, as prolonged hypoperfusion can lead to severe complications, including tissue death. Any suspected open fracture or vascular injury should be treated as a critical emergency. While most musculoskeletal injuries are not life-threatening, prompt assessment and stabilization are vital to prevent further harm. Emergency care for orthopedic injuries begins with a primary assessment, ensuring that the patient's airway, breathing, and circulation are stable. Next, a secondary assessment should be performed, focusing on the area of injury or a full-body evaluation if necessary. Standard precautions should always be followed, and EMTs should remain alert for signs of internal bleeding, which can complicate recovery. A splint is a rigid or flexible device used to stabilize and protect an injured extremity. Splinting is essential for fractures, dislocations, and severe sprains before moving the patient unless there is immediate danger. Proper splinting helps to reduce pain and makes transport safer and more comfortable for the patient. Splinting serves several purposes beyond immobilization. It helps prevent further damage to muscles, spinal cord, nerves, and blood vessels. It also reduces the risk of skin lacerations, prevents restriction of distal blood flow, minimizes excessive bleeding, reduces pain, and prevents potential paralysis of the affected limb. There are general principles to follow when splinting an injury. First, remove any clothing around the injured area to assess for open wounds or deformities. Always check and document the patient's neurovascular status before and after splinting. Cover any open wounds with a sterile dressing, and never attempt to move the patient before splinting unless absolutely necessary. Lastly, stabilize the joints above and below the injury site. Additional principles of splinting include padding all rigid splints for patient comfort, maintaining manual stabilization throughout the process, and avoiding unnecessary movement. If resistance is encountered, the limb should be splinted in the deformed position. For suspected spinal injuries, immobilize the spine in a neutral position. When in doubt, always err on the side of caution and splint the injury. Rigid splints are made of firm materials such as plastic, wood, or metal and provide strong support to an injured extremity. They are applied to the sides, front, or back of the injured limb to prevent movement. At least 2 EMTs are typically needed to apply a rigid splint properly while maintaining stabilization. There are 2 key situations where a limb should be splinted in the position found. First, when the deformity is severe, and second, when resistance or extreme pain occurs while applying gentle traction. Attempting to force the limb into a normal position in these cases may cause further injury. Formable splints, such as structural aluminum, SAM, splints, and vacuum splints, provide versatility in immobilizing various injuries. Other types of splints include air splints, pillow splints, and sling antsway bandages. These splints conform to the shape of the limb, providing both support and comfort while minimizing further movement. A pelvic binder is used to stabilize fractures of the pelvis, which can be life-threatening due to internal bleeding. It helps reduce hemorrhage from broken bone ends and venous disruption while also minimizing patient pain. This is a temporary stabilization device that should be applied as soon as a pelvic fracture is suspected. Improper splinting can cause significant harm, including compression of nerves, blood vessels, and soft tissues, leading to further injury. It may also delay the transport of a critically injured patient. Additionally, if applied incorrectly, a splint can reduce circulation, worsen an existing injury, or cause unnecessary pain. Proper training and technique are essential to avoid these complications. Most musculoskeletal injuries do not justify excessive speed during transport. However, a patient with a pulseless limb should be given a higher priority, as prolonged loss of circulation can lead to permanent tissue damage. If the nearest treatment facility is over an hour away, consider transporting by helicopter or the fastest available ground transport to ensure timely intervention. The clavicle is one of the most commonly fractured bones in the body, often occurring due to direct trauma or falls. Clavicle fractures are particularly common in children. Patients with this type of injury usually report shoulder pain and will often hold their arm across the front of their body for support. Swelling and tenderness over the fracture site are common findings. Scapular fractures are less common because the bone is well protected by surrounding muscles. However, when they do occur, they're usually caused by forceful, direct trauma to the back. The most serious concern with scapular fractures is the potential for associated chest injuries, which can lead to long-term complications if not properly managed. A common injury involving the clavicle is an acromioclavicular joint separation, which frequently occurs in contact sports. These injuries can be effectively managed in the pre-hospital setting by using a sling and swathe to immobilize the affected arm. Always ensure the patient's fingers remain exposed to assess distal circulation throughout transport. Shoulder dislocations are among the most painful joint injuries, with the humeral head most commonly dislocating anteriorly. Stabilization of a dislocated shoulder can be challenging, as any attempt to move the arm inward toward the chest increases pain. The best approach is to splint the joint in whatever position is most comfortable for the patient while ensuring neurovascular integrity is maintained. Humerus fractures can occur in three main locations: proximally, near the shoulder, in the mid-shaft, or distally, near the elbow. If the fracture is significantly misaligned, gentle traction may be needed to realign the bone before splinting. The best method for immobilizing a humerus fracture is a sling and swathe, which secures the arm to the patient's body to minimize movement. Elbow injuries can be challenging to assess in the field, as fractures, dislocations, and ligament injuries may present similarly. A common type of elbow injury is a fracture of the distal humerus, which occurs frequently in children. These fractures can cause severe deformity and may also injure nearby blood vessels and nerves, requiring careful assessment and urgent medical attention. Elbow dislocations typically occur in athletes and result from a fall or direct impact. In most cases, the ulna and radius are displaced posteriorly. A telltale sign of elbow dislocation is the prominence of the olecranon process, which appears visibly displaced. Proper splinting and prompt transport are crucial to prevent further complications. A fracture of the olecranon process of the ulna can occur due to direct or indirect forces. These fractures are often associated with lacerations and abrasions over the injured site. Patients with an olecranon fracture may experience difficulty or inability to extend their elbow, making assessment and stabilization critical before transport. Fractures of the radial head are commonly missed during initial diagnosis. They typically occur due to a fall on an outstretched arm or direct trauma to the lateral elbow. A key symptom is pain when attempting to rotate the elbow or wrist. These fractures should be splinted appropriately, and the patient should be transported for further evaluation and imaging. All elbow injuries should be considered serious due to the potential for nerve and blood vessel damage. When treating an elbow injury, always assess distal neurovascular function periodically to ensure circulation is not compromised. If distal pulses are impaired or absent, immediate transport is required to prevent further complications. Fractures of the forearm are common in all age groups, but are seen most frequently in children and the elderly. In most cases, both the radius and ulna break simultaneously. To stabilize these fractures, use a padded board splint, air splint, vacuum splint, or pillow splint. Ensuring proper immobilization helps reduce pain and prevent further injury. Wrist and hand injuries are among the most common musculoskeletal injuries and should always be confirmed by X-ray. Dislocations are often associated with fractures. Even if a fracture is not obvious, any wrist injury with pain, swelling, or tenderness should be splinted and further evaluated in the emergency department. Pelvic fractures often result from high-energy trauma, such as motor vehicle collisions or falls from significant heights. These fractures can lead to life-threatening blood loss, and in some cases, the bone fragments may injure nearby organs, including the rectum, vagina, or bladder. Early recognition and stabilization are critical. Any patient who has sustained a high-impact injury and complains of lower back or abdominal pain should be suspected of having a pelvic fracture. Assess for tenderness in the pelvic region and check for signs of internal bleeding, such as hematuria or bruising in the lower abdomen. Early stabilization and transport are essential to prevent complications. To assess for pelvic instability, place your hands on the iliac crests and apply gentle pressure to detect movement or tenderness. Do not aggressively manipulate the pelvis, as this can worsen bleeding. If a pelvic fracture is suspected, use a pelvic binder to stabilize the area and transport the patient as quickly as possible. Hip dislocations occur only after significant trauma, such as a high-speed car accident. In most cases, the femoral head dislocates posteriorly, pushing it out of the hip socket. Any patient involved in a severe crash with injuries around the knee or hip should be suspected of having a hip dislocation until proven otherwise. A posterior hip dislocation often damages the sciatic nerve, leading to severe pain, resistance to movement, and tenderness upon palpation. Because the nerve involvement can cause long-term disability, hip dislocations should be managed carefully. Prompt splinting and transport to a hospital for reduction under sedation are necessary. Do not attempt to reduce a hip dislocation in the field. Instead, splint the affected limb in the most comfortable position. Place the patient supine on a backboard and secure the limb with pillows and straps. Transport the patient urgently to a facility where orthopedic specialists can manage the dislocation safely. Proximal femur fractures are common in older adults and individuals with osteoporosis. The fracture occurs in one of three locations: the femoral neck, the intertrochanteric region, or the proximal femoral shaft. Patients typically present with the injured leg shortened and externally rotated, indicating a high likelihood of a femoral fracture. When managing a proximal femur fracture, assess for soft tissue injury in the surrounding area and apply appropriate bandaging if necessary. Always check pulses, motor function, and sensory responses to rule out vascular or nerve compromise. Immobilize the limb using a padded splint or traction splint before transport to reduce pain and prevent further injury. Femoral shaft fractures can occur at any point between the hip and the knee and often result in significant blood loss due to the large muscles of the thigh. These muscles spasm to stabilize the unstable limb, which can cause severe pain, deformity, and limb shortening. Immediate stabilization is necessary to prevent further complications. Bone fragments from a femoral fracture can penetrate soft tissue, nerves, or blood vessels, leading to severe internal damage. Always assess distal neurovascular function to check for circulation issues. Cover open wounds with a sterile dressing and immobilize the fracture using a traction splint, which helps realign the limb and control bleeding. Traction splints are primarily used for isolated femoral fractures. The main goals of inline traction are to stabilize fracture fragments, align the limb to reduce further damage, and prevent neurovascular compromise. When applying a traction splint, ensure that the patient is stable before proceeding with the application. There are several conditions in which a traction splint should not be used, including injuries of the upper extremity, injuries close to the knee, pelvic fractures, partial amputations, and lower leg or foot injuries. In these cases, alternative stabilization methods should be used to ensure patient safety. The knee is highly susceptible to ligament injuries, which may occur due to sudden twisting or direct impact. These injuries include sprains, dislocations, and fractures of the bony elements of the knee. Proper immobilization is crucial to prevent worsening of the injury. Signs of knee ligament injuries include swelling, bruising, tenderness, and joint instability. If the patient reports hearing a popping sound at the time of injury, this could indicate a ligament tear. Always splint the knee in its current position and avoid excessive movement during transport. Knee dislocations are true emergencies that can threaten the viability of the limb. These injuries often result in severe ligament damage and may lead to a complete loss of joint stability. The direction of dislocation is described based on the position of the tibia relative to the femur, with posterior and medial dislocations being the most common. One of the most serious complications of a knee dislocation is damage to the popliteal artery, which can result in loss of blood flow to the leg. Other complications include nerve injuries and chronic joint instability. If distal pulses are present, splint the knee and transport immediately. If pulses are absent, this is a critical emergency requiring rapid intervention. Fractures around the knee can occur at the distal end of the femur, the proximal tibia, or the patella. If the patient has a good distal pulse and no significant deformity, splint the limb with the knee straight. However, in cases of severe deformity, the knee should be immobilized in its current position. If there is an adequate pulse but the knee is significantly deformed, splint the joint in the position found to avoid causing further injury. However, if there is no pulse below the injury site, contact medical control immediately, as this may indicate a vascular emergency. Never use a traction splint for knee fractures. Patellar dislocations are most common in teenagers and young adults, particularly in sports-related activities. The patella typically displaces laterally, causing visible deformity and extreme pain. In the field, the knee should be splinted in the position found, and the patient should be transported for medical evaluation. Fractures of the tibia and fibula can occur anywhere between the knee and the ankle, often affecting both bones simultaneously. These fractures can lead to severe deformity and instability. Stabilize the leg using a padded long leg splint or an air splint, and apply gentle traction if necessary to correct gross misalignment. The ankle joint is frequently injured due to its weight-bearing function and susceptibility to twisting forces. Injuries can range from simple sprains to severe fracture dislocations. Any ankle injury that results in pain, swelling, localized tenderness, or inability to bear weight requires immobilization and further evaluation. Emergency management of ankle injuries includes dressing open wounds, assessing neurovascular function, and correcting gross deformities with traction if necessary. Before releasing traction, a rigid splint should be applied to maintain stabilization. Proper immobilization helps prevent additional soft tissue damage. Fractures and dislocations of the foot may involve the tarsals, metatarsals, or phalanges. In cases of severe impact, the force can be transmitted up the leg to the spine, potentially resulting in a lumbar spine injury. Always assess for secondary injuries in patients with high-impact foot trauma. If a foot dislocation is suspected, assess for pulses, motor function, and sensation to rule out neurovascular compromise. Foot injuries are often accompanied by significant swelling, but may not show obvious deformity. Use a rigid padded board splint, an air splint, or a pillow splint for stabilization, ensuring that the toes remain exposed for circulation checks. The general treatment for strains and sprains is similar to that for fractures. The Rice's protocol, rest, ice, compression, elevation, and splinting, is the standard approach. While strains and sprains may not require rigid immobilization, compression wraps and supportive splints can aid in reducing pain and swelling during transport. In some cases, surgeons can reattach amputated limbs if the severed part is properly preserved. Immediate care includes controlling bleeding with a bulky compression dressing or tourniquet and immobilizing the injured stump. Partial amputations should never be fully severed in the field, as preserving blood flow increases the chances of successful reattachment. For complete amputations, the severed part should be wrapped in a sterile dressing, placed in a plastic bag, and kept cool in a container with ice. However, it should never be placed directly on ice, as freezing can cause tissue damage. Follow local protocols for proper preservation and rapid transport of the patient and amputated part. Compartment syndrome is a serious condition that typically develops 6 to 12 hours after an injury. It is most commonly associated with fractured tibias and forearm injuries in children. The condition results from excessive bleeding, severe crushing injuries, or the rapid return of blood flow to an ischemic limb, leading to increased pressure within the muscle compartments. Compartment syndrome is characterized by pain that is out of proportion to the injury, pain on passive stretching of muscles, pallor, decreased sensation, and decreased power in the affected limb. If left untreated, this condition can cause permanent muscle and nerve damage, potentially leading to the loss of the limb. If compartment syndrome is suspected, the affected limb should be splinted at the level of the heart to minimize swelling. The patient must be transported immediately for emergency surgical intervention. Reassess neurovascular status frequently during transport, as worsening symptoms may indicate increasing pressure.